Thank you so much, Powell, and just phenomenal day today, right? I mean, thank you to you and Harris and everybody here. It's really been a tremendous day. I feel like I've learned a lot. I've met and talked to some really amazing people, and just had a lot of fun. But you know, it is about an hour past cocktail hour, so I'm going to try to be real quick here if I can, and hopefully we have some slides here. Do we? Do you know if? Okay, terrific. Okay, great. So I wanted to talk a little about our Food as Medicine program at the American Heart Association and how this might be related to what we've talked about today with regard to brain capital. So I am pressing the advancer here. Maybe you can advance the slide. It doesn't seem to be moving. There you go. Thanks. So as I think this group probably knows, food is essential to health. It's essential to brain health as well. Can you back it up? Yep, that's perfect. Thanks. What's that? Got it. Okay, thanks. So poor nutrition is the #1 driver of poor health outcomes in the United States. I imagine this is true in a lot of other parts of the world as well. Here's some really scary and impressive statistics. 1 in 2 Americans have diabetes or pre-diabetes. 3 in 4 are overweight or obese. I think we're among some of the worst countries in that regard. And 90% have suboptimal cardiometabolic health. And poor diets are actually the leading cause of death. And these effects are even greater in marginalized and underrepresented communities. And it's a terrible problem among our youth as well. We talked about mental health in youth earlier today, but cardiometabolic disease is a growing problem as well that in the future will contribute to their cognitive and mental health as well. So 25% prediabetes, 1 in 4 overweight or obese, and fatty liver disease in a significant proportion as well. And of course, this is due to consumption of unhealthy foods and underconsumption of healthy foods. In terms of costs, which is one of the things that we're very focused on here today, I think about 85, some people would even estimate 90% of all healthcare spending in the United States is for management of diet-related chronic diseases like diabetes, cardiovascular disease, and so forth, with a total cost of about $1.1 trillion per year. And in fact, every dollar that we get from the food system gets lost in health harms on the other side. So we're not actually generating any capital or income from food systems because of that. And you can see the tremendous costs of diabetes to our system, and these are treatable conditions. Food affects multiple systems throughout the body: diabetes, cardiovascular disease, cancer, arthritis, liver disease, kidney disease, but also brain health. And here are just a couple examples of this. This is really a meta-analysis of meta-analyses. The data is too small, of course, but basically what it shows is that there are certain foods that are associated in this case with an increased risk of stroke. This is ischemic stroke, and those would be meat, and particularly processed meats, and then certain foods that are associated with a decreased risk, like fruits, vegetables, coffee, tea, and so forth. This is data actually from Columbia University, my colleague Adam Brickman, showing that dietary flavonols have a beneficial effect on cognition, but it was really limited in their analysis, and this was part of the Cosmos study, several thousand individuals, and when they looked at the results by tertile of consumption of dietary flavonols at baseline, they found that these effects were greatest in those who were in the lowest tertile of consumption. So in other words, replacement or repletion of low dietary flavonol levels led to improvement in cognition in these older adults. So these are just a few examples of how foods are related to cognition and brain health. And there are a number of other examples. Neurologists are very familiar with food serving as a trigger for migraine. So aged cheeses, processed meats, chocolate, bananas, and so forth can trigger migraines. Probably many of you have heard of the ketogenic diet, which can be used as a treatment for some forms of epilepsy. But diet has also been found to play a role in neuropathy, neuroimmune disorders, autonomic disorders, and there's a whole literature on food and mood, or how food is related and nutrition is related to mental health as well. So the American Heart Association just launched a national platform for food as medicine research. It's primarily a research initiative. This is being launched with $50 million in funding from the Rockefeller Foundation, and we continue to raise more money as well, with a total budget that we estimate will be at about $250 million to do large-scale clinical trials of food as medicine approaches to improving cardiovascular health, and really to demonstrate the cost-effectiveness of food as medicine approaches so that health care payers, insurers, perhaps governmental agencies will pay for food for individuals with diet-related diseases. This shows what's called the Food as Medicine Pyramid, developed by the Tufts Friedman Institute for Food and Nutrition, illustrating that at the bottom, the most basic aspect of this is population-level nutrition policies and programs, and then other government food programs above that, and ultimately affecting people who may already have disease or are at high risk of developing disease. There are specific, what we call food as medicine programs, like medically tailored meals at the very top, or produce prescriptions, in other words, prescribing fruits and vegetables to people, either in addition to or potentially instead of medication. And those would obviously apply to fewer individuals then. And everybody would receive nutrition counseling and education. So there are several studies out there. Many of them are small clinical trials or pre-post analyses that demonstrate the benefits of food as medicine programs in selected populations. But there's really a lot of missing data in this, and that relates to how long do you give people food for, how much, how many meals a week do you need to feed people, how do you get it to them, how do you engage people in these treatments to begin with. People often sign up, but they don't necessarily fulfill the vouchers that you may provide to them. If you send people meals, they may put them in the back of the fridge and not eat them, or other family members may eat them, but not the person who actually has the disorder. Can we actually change behavior and improve people's health with these meals? And what are the populations that this would be of most benefit in? And several other questions as well. And as I said, the ultimate goal is to demonstrate cost effectiveness so that payers will take this up. So we envision a 10-year initiative. We've just completed our planning phase. In fact, today we released a request for proposals to the general research community for grant proposals. Our plan is to begin with behavioral interventions first, designed to test some of these behavioral questions, like how do you get people to enroll in these programs? How do you ensure that they use the vouchers? How much of a incentive is necessary? 20% towards the purchase of food, or 40%? How does that change people's likely use of the vouchers, and so forth? So there are a lot of these initial behavioral questions that we'll address in smaller pilot studies, and that's what the RFP that was released today is about. The goal is to learn from those analyses and then go on to larger and ultimately definitive several thousand person national trials that will test this in patients with heart failure, people with hypertension, people with diabetes, pregnant women, and so forth. Not necessarily all of those, but in several different populations. And so that's our intention. And we'll be trying to address several questions. I mentioned some of the initial behavioral and implementation science questions, then some of the short-term behavior change. How do we get people to take on these treatments? Then the longer-term behavior change. How do we get people to sustain healthy eating over time? And ultimately, what are the clinical efficacy and effectiveness and health economic or cost effectiveness outcomes as well. And so there are a number of questions that we hope to address with this, including implementation science, behavioral science. And this initiative is not really focused on brain health, but, you know, as a neurologist and member of this Brain Capital Alliance, I'm certainly hopeful that some of the proposals we'll get and some of the work that we'll do will address the relationship between food, or food as medicine, and brain health as well. So you can imagine questions about what type of diet is optimal for the healthy brain to function. How can we best enable people with cognitive impairment to eat healthy diets that might preserve their cognition for a longer period of time? And then we mentioned this a little bit before, and I thought it was fascinating to hear from Elizabeth from the Wharton Neuroscience Initiative. Again, I think that these questions about behavior change are relevant to brain health, right? It's behavioral economics, it's behavioral science that will determine, and brain science ultimately, decision neuroscience, that will determine how we can change these behaviors. In fact, I should have said that the volunteer lead on this initiative for the Heart Association is Kevin Volpe, who is a faculty member at Wharton, MD, PhD, and expert in nudges and health incentives at the Wharton School and the School of Medicine at Penn.